Now the basilic vein tends to be my favorite target. It runs on the medial side of the arm. It's usually a pretty big target, and it's just deep enough that IV drug users aren't able to abuse that vein. Your setup is going to be the same as your normal IV setup, except you're going to have the ultrasound machine, and you're going to need a longer catheter. You absolutely cannot use the regular 1.1 inch IV catheters. You have to have the longer catheters, either 1.8 or 2.5. I can't stress this to you enough. The reason for this is even if you do get a 1.5 inch catheter in ultrasound guided, you can see here that just the tip is in. You have to go through more subcutaneous tissue, and so even if you get in and are able to cannulate it, this tiny tip in here is going to pull out as soon as they move their arm or do something else. Whereas if you have a nice long 2.5 inch catheter, you've got a fair amount of catheter in the vein. They last longer. Also, the angle you take is important. This is the biggest issue I see with nurses learning this. They're used to placing lines at a very shallow angle, but if you do that, then you're going to use a lot of the IV catheter before you get to the vein. You're going to have much left in the actual vein. So you have to take a little steeper angle, and then you can flatten out once you actually get to the vein and thread the catheter. But by taking a steeper angle, you don't use all of your catheter up in the tissue before you get there. You really have to set up well beforehand to maximize your chances for success. This is bad. You don't want the machine on the same side where you have to look back and forth, twisting your neck to see the IV and the screen. You can have it on the same side if you can comfortably just look up and down from the machine to the IV catheter, not move your head around very much. But best, I think, is to be able to look across the patient and just move your eyes up and down to the screen and to the needle without moving your head or neck at all. When picking a vein, you first have to be able to tell vein from artery. As you can see here, the vein on the right is completely compressible. As you compress this artery on the left, it becomes more pulsatile. It doesn't compress as the vein does. You can also adjust the gain to get a better image. You see as we turn the gain down, we don't see the vein quite as well as when we turn it up. So adjusting the gain can be important. The depth as well. When you find your vein, you can see the compressible vein on the right there. Once you do find a vein, you can actually look and tell how deep it is. You can see that we have 2.6 centimeters down at the very bottom here. So the anterior wall of this vein is less than a centimeter deep. So we know what kind of success rate we'll have with this IV placement. Again, remember, the deeper you are, the less likely your IV is going to survive. Now, do you place it in long axis or in plane, like on the left, or in the short axis, out of plane on the right? There are advantages and disadvantages to both. In this study, they talk about the fact that in the long axis group, needle tip visibility is much better. You're able to see the whole needle the whole time, and they tend to advocate for that approach. However, in this study, you can see that they found the success rate was a little higher in the short axis group than in the long axis group, but not by much. In my general experience, it seems to be a little easier to learn the short axis approach, but once you get better, the long axis approach is probably the way to go. A little less risk of posterior wall puncture, which we'll talk about more. Personally, I think you should learn both. You should have both of these arrows in your quiver. The more tools you're able to have and pull out, the better success you'll have. For example, different situations call for a different approach. So this is your vein. What if your artery is right here, posterior to the vein? Which approach would you use? Well, the long axis approach would probably be more appropriate, and let me show you why. With the short axis approach, you're only seeing the part of the needle just underneath the probe. So if we look here, even though the needle tip is in the vein, the beam is hitting the back of the needle. So it looks like, when we have a short axis image, that this needle, as you can see on the left side, is still above the vein. So by the time it looks like the needle is at the vein, your needle will actually be through the posterior wall and possibly hitting that artery if there's an artery just behind it. So this is a long axis view. You can see the whole needle here, and you can see that the tip is sitting in the vein. But if you have a short axis view and your probe is back here, you're going to see the needle shaft, not the tip. So it's going to look, when you turn in the short axis like that the tip is above the vein, as you can see here. So the solution to not having this happen, to see the back of the needle tip in the short axis, is that you have to follow the tip. As you can see here, as we're placing our IV, going in deeper, When we get to the probe, it's so easy to go past the beam. Because what you need to do is follow the tip with the probe the whole time. By doing this, you prevent the posterior puncture and you see the tip. The other thing to do is this. As you see the tip, then you move the probe. Every time you see the needle tip, if you move the probe just ahead of the needle tip until you lose it on the image, then you know that you're never ahead of the probe. The stepwise approach is probably the best. Again, you're coming in, you see the tip, so you move the probe. Tip, move the probe. Tip, move. All the way following the tip into the vein. That's the safest way to do this as you're starting out. You can also rotate the probe. If it looks like the needle tip right here is in the vein in the short axis view, you could rotate 90 degrees like this, and you can see that now definitely the whole needle is in the vein. Here's a demonstration of the short axis. And watch here, we're placing the IV, and once you see it on the screen on the left, watch their hand on the right. The probe is going to slide and move with that tip. You can't just keep placing the needle. You have to follow it with the probe all the way till you get into the vein. Making adjustments is also a key in short axis. You're going to see it appear either to the right or the left. Here you can see it appear to the left of the vein. You see it on the left of the screen. So as you're following the needle tip in, you're slowly adjusting to the right. You keep adjusting all the way to the right until you follow that tip directly into the vein. So what if your artery was to the side of the vein instead of just behind it? Which approach would you use then? Well, possibly the short axis approach at that point, because then you're more worried about being off laterally than the posterior puncture. There's nothing just behind the vein to puncture, so you're not quite as concerned about that as you would be if there were an artery just behind there. But we just covered the short axis. So let me show you how to do the long axis approach. It really is a beautiful approach. Here you can see the needle coming in just underneath the probe, and you see the entire needle the whole time as it slides into the vein. Then once it's in the vein, you can also slide the catheter off. When you cast that off, you actually see the catheter in the vein as well. This is really nice confirmation that you're in the vein, as you can see right there. Everyone sees this image and they think this is the way to go. This is definitely better than the short axis. And personally, I do prefer it, but it is a little more difficult to line up the probe, the needle, and the vein. So it's slightly more technically difficult, but once you get good at it, it's a really nice technique. And you can make adjustments when doing the long axis approach as well, just like the short axis, but they're a little bit different. In this case, when you have a nice image of a vein and you place your needle just underneath the probe and come in, if you're in the body and you don't see the needle, then you must immediately stop. And what you can do is fan to each side just off of the vein until you find the needle. And if you find that it's just lateral to the left of the vein after fanning to the left, then you know you need to adjust the needle to the right a bit. Here you see an example of this. We place the needle, we don't see it, so now we're fanning to the left, don't see it, fanning back onto the vein, back to the right, and there's the needle. So we know we're to the right, so we need to go to the left. So we're adjusting to the left a little bit before we actually advance. Now we've adjusted enough to where we're lined up with the vein, and we can follow the whole needle into the vein. So what if the IV quits working? Which is not that uncommon of a situation. I already showed you that up to 70% of IVs fail if they're in a really deep vein. You can actually check that. It is a little more difficult with no sun guided catheter to tell if it's infiltrated or not because they're deeper. You don't have the extravasation right on the surface that you can feel. So it's important to be able to recognize these quickly. Here you can see extravasation. You see the edema within the fluid. That's an extravasated IV. However, if you go look at the IV when we're worried that it may be extravasated and you see this, you flush it and you see nice flow within the vein, then you confirm that no, this is indeed still in the vein. A few pitfalls and tips. Smaller patients are definitely more difficult. This makes a huge difference in adults, and it makes a difference in kids too, but the success rates don't skyrocket in kids like they do in adults. It's a tougher skill to learn. Also, beware of the posterior puncture. We've talked about this several times, but if you're in the short axis, be very careful. You're always following the tip and you're not looking at the shaft of the needle. Tinting of the skin can be an issue. You can see here that anterior wall is completely tinting until it pushed all the way to the posterior wall, and then when the needle popped through the anterior wall, it was already through the back of the vein. I'll play that for you again. You see that anterior wall all the way on the back, and then boom, you see the needle in the tissue just posterior. Now it's back into the vein. So the solution to this is a couple of things. If you do poke through and do a posterior puncture there, then just slightly pull back after the anterior wall has rebounded, and you should be in the middle of the vein. However, it's better not to do that though. These definitely blow more often if you've poked multiple holes in the vein. Instead, when you do see the tenting, the thing to do is to flatten your angle. For example, if you're coming in at this steep of an angle, it's very easy to press that anterior wall down to the posterior wall. But if when you're coming in, you start to see a little bit of tenting, if you flatten out, you can push into the vein instead of backwards towards the posterior wall and pop into that vein easier. Again, when you got to this point, if you were coming in, pressing this anterior wall, then you would just flatten a bit and start pressing this way so that you can pop in a little sooner and be in the vein, not posterior to the vein. There are really 3 tips when it comes to placing an IV. Number 1, the tip. You have to follow the tip. That's key when you're doing a short axis approach. You have to follow it slowly, make sure you don't get ahead of the probe, or as you come in, go stepwise. See the tip? Slide, tip, slide, tip, slide until you get to the vein. The second key is the tip. When you're doing a long axis approach, the in-plane approach, you have to see the tip, the whole needle at the whole time. You cannot advance the needle if you don't see it on the screen. And then the third key